will just be a huge honor today to be podcast interviewing Denture Queen on Instagram. Her name is Dr. Valerie Cooper. She's a private practice prosthodontist with a passion for dentures. Called the Denture Queen by her prosthodontic co-residents, the name stuck and her love for removable prosthodontics grew with time. Dr. Cooper presents a systematic approach to digital denture treatment, which she has been refining since she switched to all digital denture fabrication in 2015. Dr. Cooper's practices are located in Dayton, Ohio, her hometown. She owns a practice limited to prosthodontics as well as a general dentistry practice. Since 2014, she has fabricated free dentures for patients in her community during National Prosthodontics Awareness Week. Many volunteer lab technicians, students, and prosthodontists help prepare up to 20 dentures in a single week with the conventional denture process. Once the process became all digital and required less human work, the focus turned to education during the NPAW 2016 and 2017. In 2018, her plans are to fabricate more free dentures than ever before using 3D printed technology. And I want to tell you that I'm here in Phoenix, Arizona, and they just had the Digital Dental Conference. You were the keynote speaker.
Yes.
You didn't even leave town. You came by my house because you're lecturing again at another big conference right here in our backyard. You are the bomb, and thank you so much for coming by my house. So I got to ask, it's of all the things that go into dentistry, why the Denture Queen?
Well, I didn't intend to go into dentures. I actually didn't even like them much at all until my residency. Actually, when I graduated from dental school, I didn't like them at all.
And
I had
which
the
dental
usual
school was that?
Ohio State.
The Ohio State.
The Ohio State.
The Ohio
yes.
State.
I had the usual problems that most dental students have. They don't like dentures. They don't feel confident. They don't know very much about it. And so it wasn't why I went into pros. But I did go into pros. And my instructors kept giving me all the difficult denture patients, and more so than a lot of my other classmates. And that kind of, what happened is I gained the love for the challenge of the difficult denture patient. So, you know, the lady who has no ridge, wants to eat celery and carrots, has a bag of rejected dentures. Most people are like, no way, not touching that. I'm like, well, maybe I could try this, or maybe I could try that. So the thrill of the success in that case is what makes me love it.
You know, I'm a huge fan of yours, and I want to get you involved in Dental Town any way I can, because when you go to all these conventions, the limelight is always the all-in-four. Like I'm lecturing next weekend in Vegas at the MegaGen Symposium, and everybody in dentistry, they always love the rich, the famous, the Lamborghini, the all-on-four at $25,000 an arch. But I'm from Kansas, and Arizona is pretty much Kansas, and it's not, you know, it's not Hootie Tootie, California or Beverly Hills or anything like that. And there's 100 all-on nuns,
Yes.
a denture done for everyone all-on-four. What do you think the all-on-four, 25,000 arch, how many full-mouth dentures are done on nun implants? What do you think the ratio is?
I don't know. Probably 100 to 1.
Oh, yeah.
I you know, that sounds totally reasonable, but I
mean, when I tell people in Phoenix, I'm in Phoenix. I'm not in Scottsdale. I'm not in Paradise Valley. When I tell them it's $25,000 an arch, some people just laugh.
Yeah.
I mean, it's like a joke.
That's also my experience in Ohio too. So I know friends of mine who have successful pros practices in big cities, and they're like, people get dentures? I'm like, yes. And it's not always so much about the cost. Dr. Farran has done studies about people who are presented with, you can have implant dentures for free. Some people actually turn that down. And there's a lot of people, especially elderly people, who say, I'm worried about the surgery. I'm worried about the impact on my health. And they don't want implants. The other thing I would want to mention is for the all-on-four folks, you have to know dentures to be good at all-on-four.
Well,
it's the basics.
That was Carl Mish's intro to implants. He was first a denture-making prosthodontist. And these implants came out, and everybody kept saying that these titanium implants were snapping. And he goes, yeah, well, yeah, because the denture was so bad. If the denture would have been done right, it would have the titanium implants wouldn't have snapped.
Yeah, you can't fix all the problems with implants.
Now, do you place implants too?
A few, but
Yeah.
not too many.
But being Denture Queen, is the majority of your practice dentures?
No, I would say I have an average prosthodontics practice. So I do implants, crowns, just general pros in addition to the dentures. But I like doing the dentures, so I try to get them. So I would say I do more than most pros. But
So you're, without a doubt, I mean, you just spoke at the largest digital dental conference, period. It sold out.
yes.
You were the keynote speaker. That's just, did you tell your mom? Did you at least, did you take a selfie and tell mom, I'm keynoting at the biggest denture? Did you?
Yeah.
Okay,
yeah.
good.
It's kind of weird for me. I was voted most quiet in dental school. I was also extremely shy in all my other classes. So I never, ever thought I would speak in front of that many people or actually have the desire to do so.
So did you, were you scared? Were you nervous, or did you love it? Was it fun?
No, I really don't get scared. I mean, I'm a little nervous. Everybody's nervous when they start, talking to people. But if you ask me about dentures on a bus or in a taxi, I will go on and on and on and on. So I honestly find it easy to talk about dentures. I talk about them for 2 days. So it's once I have an audience that actually wants to hear what my interest is, I will just talk their ear off.
If you go to my YouTube channel, it's youtube.com/Dentaltown Magazine, and then you click videos, then you can sort. Oh, here it is. My most viewed. I've got 1,060 classes on podcast on. The number one view, that went over 10,000 views on just YouTube alone, was my journey with Christy Lind. Have you heard of her? Mm-hmm. And she's another phenom because she was a young bride who just got married and needed a denture. And people that want to talk about dentures, here it is right here. People that want to talk about dentures, who are girls going to talk to? They don't want to tell people that they don't have any teeth or losing their teeth. I mean, these girls don't even want to talk to their sister or their friends. So it's just great pain, and I've seen it. And there's also, if you talk to suicide people, there's people who lose all their teeth, get a denture, and check out. And I find it amazing how mismatched supply and demand is when, of all the podcasts I've done, that just on YouTube alone, the only one that passed 10,000 watches on YouTube was about a denture. And this is my new mantra. It's like the dentists always ask, what bonding agent you use. And it's like, well, what % of the people that call your office go to voicemail? Isn't that more important than what bonding agent you use? So I just love the fact, and I never would have pictured, if someone would have said to me, who's going to be the keynote speaker at the biggest digital dentistry conference? I thought it'd be some 65-year-old Brooklyn dentist with a mustache and crooked teeth, up there slugging out. And it's like a beauty queen.
Thank you.
I mean, it's amazing. So you have so much to offer because these dentists need to get focused on real world, real dentistry. And then they want to be a cosmetic dentist, and they're in Parsons, Kansas, and they're taking every course by some guy from Beverly Hills. And it's like, dude, do you not know you live in Kansas?
They can do cosmetic dentistry the next day by focusing on dentures. I think it's the most artistic of all the types of dentistry. It's certainly more difficult than fixed prosthodontics. Doing veneers, for example, you can only do so much. You can't change very much about someone with veneers, but you can change their whole face with dentures. So, yeah.
Because that's what the American Witch is, right? She went edentulous, and so she's overclosed, which makes her look like she has this big nose and this big chin, when basically if you just opened her up and had some teeth fill out the lips, she wouldn't be the Wicked Witch.
Totally different, yeah.
Yeah, totally different. You went digital dentures before anybody that I'm aware of.
Yes.
I mean, Ryan McCall is like the denture guru on Dental Town, and he pays homage to you. I mean, he just bows down and says you're the digital denture queen. So is digital dentures, is it bleeding edge, or is it really here?
I think it's really here right now. When I started doing digital dentures, I was fortunate that I have a specialty practice, fee-for-service practice, so I was able to start making digital dentures when the costs are higher. And I know that an average doctor who is in PPOs cannot do expensive dentures. The lab bill that you can afford is relatively low. So really, it's reached kind of a tipping point with a lot of the newer technology that's out now. There's a lot of different software systems. There are different ways to manufacture dentures, and it's becoming attainable for the average provider.
That's the only line I think dentists should be fighting over. It's like, so the employer wants to help his employee, so he gets a dental benefit. And because it's not insurance, it's just a benefit. It's only a benefit if someone else paid for it, because insurance is, 100 people drive a car, you all have insurance, but only one person here stacks the car. Mm-hmm. But in dentistry, it's just only benefit because if you insured 100 people, everybody needs to see the dentist twice a year.
Yeah.
But it's not that the PPO says that you can only charge, say, $700 for a denture. It's the line they say that they tell the dentist you can't charge more than that.
Right.
And that's the only line in the sand that the dentist should be fighting for. That if you want to, like, if I give 4 people a $100 benefit for a filling, and I go to you and you say, well, I'll do a $100 amalgam, nothing out of pocket. Awesome. Someone else say, well, tooth colored's $200, you give me $100, you give me $100 out of pocket. Next person might say, well, I want same day dentistry, I want a CAD cam. I want to apply my $100 to a $500 CERAC. And next person like me might say, well, I only have gold in my mouth. I just want to do 100. But the insurance company cuts off all the other markets, because when a denture factory doesn't take insurance out here in Mesa, I mean, a lot of retirees, they advertise the value price, and it might be $500 for a full set. But then you go up there, and then when you get in there, they show you the premium that might be $1,000, and then they show you the Supreme that might be $2,500. And then they tell you that on 2 implants might be $4,500. You know what I mean? It's a stair step. And, GM has the Chevy. And it started in the beginning where a Chevy was going after the Model T, same price, $668. But Henry Ford did that. He was like denture companies today. There's nothing beyond that. And then people complain, well, the wheels don't come off. So $100 more from the Chevy, which is the same price as Model T, you could have a Pontiac where the wheels come off. For $100 more, you could have a Buick that had the spark plug from Indiana, because people didn't like winding up their car. For $100 more, you could have a roof. And then the Cadillac, which was $100 above that, had the new technology from Motorola, which was the radio.
Right.
Well, current dental insurance today, it would just be you can only have a Chevy, and you cannot ever have a Pontiac with removable wheels, a Olds with a spark plug, a Buick with a roof, and all of those things in a Cadillac. And that is just absolutely wrong. These PPO doctors, they should be able to take that supplement and say, hey, yeah, we can give you a value denture for this PPO price, but would you like to apply it to a premium or a same day or a digital or over implants? Mm-hmm.
I think that's why so many dentures are made in corporate denture centers where they don't take insurance and they're all cash based. And so, but I do think that digital dentures, it's not about making a more premium product. It's about the way that you make dentures that is so different and more forgiving for the average provider and more fun. So I would hope that a lot more regular doctors start making dentures, even though they may have a PPO practice, because they'll be able to.
So let's talk specifics. How do you make a digital denture? What technology you have to buy? What kind of investment? What techniques, materials?
Really, you don't need to buy anything. So most of the time, you can start with making a preliminary impression. I'll just go through the most popular approach that most laboratories work with their doctors. You make preliminary alginates. You send those to the lab. They make custom trays and wax rims. So you make, at your second visit, you make your border molded final impressions, and you reline the wax rims, mark them, make a bite, your normal things. You send those custom trays and wax rims back, and your lab scans them. Then they generate a design, and you can see that design. You can ask for design approval. Then they'll mill or print a solid set of denture try-ins. One of the things I love about the try-ins is that you can determine if the dentures fit. You could send them home with your patient and say, chew on these, try them out. You can make adjustments to those try-ins, knowing that any adjustment you make will be reflected in the final dentures. Take photos with those try-ins in, and when you're ready, send them back to the lab. They will scan those try-ins and generate the final design based on your comments, your patient's comments, the photos, and all of those things. So that's the kind of the I like to go a little more accelerated than that. I do a 2-appointment denture, but that's the typical route that most people are
So the
going
typical
through.
route was how many appointments?
Preliminary records, final impressions and wax rims, try-in, deliver.
So 4.
Yes. Now, Dr. Stephen Wagner has a 3-appointment approach, which is really unique and novel. He has YouTube videos on it, so I would just suggest people look at that. But my approach is a little bit different. So I do a 2-appointment denture. So my first appointment...
Did you get the idea from that, what was that movie, Something About Mary? It was the 6-minute abs.
So why not
And
5-minute abs?
Was that Something About Mary?
Yeah, I mean, nobody has it. No, there's plenty of 2-appointment denture approaches.
Is
but
there?
I think mine is the best one. So what I do is most people who need dentures or seeking dentures already have a set. And most people want the same things. They want a little bit bigger smile. They want whiter teeth. They want a little better fit. But the dentures they've been wearing are okay. And most people are actually very comfortable with the dentures they've been wearing. They like the teeth. They like the size. They like the borders. So all I do is I make reline impressions with their dentures and a bite. And then I use my intraoral scanner, which is a Trios, and I scan the dentures, remove the impression material, send them home with their dentures. So my average appointment is about 60 to 90 minutes, depending on if it's a single arch or both arches. And then I will create a new design and fabricate the final dentures.
So you bought the 3-shape Trios.
Yes.
You take their existing denture, use that as a custom tray.
Yes.
And what impression material do you use?
Right now I use a bunch of different Aquasills. So Aquasil Rigid if I want to add to the borders.
Dentsply Sirona?
Yes. I also use Monophase as a single step impression sometimes. And then I use their light body or a wash if I need to.
So after you take that impression, then you just scan it.
Yes.
And are you scanning it with a wand, or is
Yes.
there? Because I know when you walk into labs, a lot of their scans they just put it in a box.
Right, which if you have a box scanner, use it. But I kind of focused on using the Trios or the intraoral. I've used other ones too, just to help make this process more accessible to a doctor that, say, is going to have an intraoral scanner but not a lab scanner. You definitely want to use a scan spray. So I use OptiSpray to spray these before I scan them.
Spray the impression? Mm-hmm. And what does the OptiSpray do?
It actually, based on my limited research, it has improved the accuracy of the Trios scanning and impression material, because intraoral scanners are not necessarily intended to scan large, smooth, flat areas like a denture impression. So if you can improve its accuracy, then it's better.
And it's just a clear spray. It's not a white powder or anything.
It's sort of powdered. Yeah, it makes the impression material matte instead of shiny.
So you do that on a tray or in your hand?
In your hand.
You just scan that in your hand?
Yes,
Do you have a YouTube video on
I
that?
do.
Can you post it on Dentaltown?
Sure.
So, I don't know if a lot of people don't know this, but the reason some people's their YouTube videos get so high is On Dentaltown, you can put the name of your YouTube video in the link. Mm-hmm. But when you share a YouTube video, it has link, but the next button over is embed. If you click embed, that's the code. So you copy the code, and then on Dentaltown, there's a little YouTube button. You click that,
And it
boom,
goes right there.
Drops right in there.
Yeah. So
And there's so many dentists who, had 200 or 300 views on their YouTube deal, and they dropped their YouTube, and Dentaltown has 250,000 members. And next thing you know, they got 10, 20,000 views on their YouTube
okay,
channel.
well that's good.
And then a lot of those people will subscribe to your YouTube channel.
Mm-hmm. So my technique is called the cupcake technique.
Only the Denture Queen would have the cupcake technique.
Because it's just like holding a cupcake and frosting it with your intraoral scanner. And then it's got an entire analogy. I went too far with it, but it's kind of funny.
Well, let's hear it.
So first you hold the denture this way and you scan it with your intraoral scanner, just like you're frosting a cupcake. And what do you do when you're done frosting it? You peel the paper off. So you're taking your scanner around the edges, down the incisal edges of that denture. Next step is you take a bite out of each side of that cupcake. So you're taking the bite with your scanner. And then I have this additional optional step called now brush your teeth. Because that's the last step when you're eating a cupcake, right? You got to brush your teeth. So you actually take the scanner and have the patient smile really big and then brush their teeth with the scanner, which captures their lips and the tissues around their face, including their nose and chin, which you can take that and merge all of that data into a virtual patient. So now, the reason why in my technique I don't do a try-in most of the time is because you don't need a try-in when you have all of that information. You have their face, you have a photo, you have their old dentures that they usually like and want to stay about the same size of teeth, same position, same shape. So when you have all of that, you can most of the time skip the try-in in patients who are, accepting of that kind of an approach.
So then the next appointment's delivery.
Yes.
And do you do all this with one lab, or do you use multiple labs?
Well, there are several different labs who could do this. I work directly with Avident.
Here in Scottsdale?
Yes. And I'm allowed to do that because I'm a prosthodontist. They don't normally accept general dentist clients directly, but there are quite a few partner labs that you can work with. But I work directly with them because I wanted to be able to change the setups myself and do all of this myself. And I'm weird and crazy. Most people don't want to work directly with the manufacturer.
So you send yours to Avident,
Uh-huh.
but I could not because I'm not a prosthodontist.
Well, they don't mean prosthodontist. They mean like if you have a denture-only practice, or you are a pros and you demand control over every step of that setup, then you can work directly with them. But most of the time, I suggest that doctors work with an experienced technician who can help and has a lot of knowledge about borders and, setting the teeth correctly and so on. So if you really desire to learn setting teeth and putting them in the right place and all of that, you can do it and work with some of these people yourself, but I don't recommend it.
So Avident, it's avident.com.
Yes.
Ava,
Yes.
what is the Ava for the dent?
It's avatar. It's an avatar denture. That's the root of their name. And I actually think that that's brilliant because I just mentioned this in my presentation that the term digital denture is actually a big no-no according to the glossary of prosthodontic terms. They want you to
Digital
call
dentistry?
they want you to call it a digitally fabricated denture because the denture is not a digital product. It's not a digital denture. It's an actual denture. I think that's missing the point. I think that the digital denture is a unique entity because it's not just the denture, it's everything that went into making that denture. All the information is still maintained, which is critical. So if you remember back to my workflow of records, deliver. What happens if you deliver a denture and the patient says, I don't like it, the shade isn't right, or these teeth, the middle doesn't line up, and it happens all the time when we make dentures that you place it and then it's not right. And you're sitting there thinking, do I, try to talk them out and say, no, that shade looks good. It matches your eyes, look. Or do you just do what they want and make it right? So this denture is not a normal denture where you can't really go back. You have to start over if you're making a denture conventionally. A digital denture, you can just reorder it in a different shade. You have all the data. You still have your impressions. You still have all of that information maintained. And so if there's a problem like the midline, you want to move the midline exactly 2 millimeters. Normally with a conventional approach, if you ask your lab to move the midline 2 millimeters, what happens? They do, but then they also can't all the teeth. Or they, kind of shift it and don't resettle the posterior teeth, and now you've got this weird unevenness. With a digital denture, you can say 2 millimeters, you click 2, push enter, and the whole thing moves. It's like precisely.
I've always thought the midline was the most bizarre concept. I know in beauty, when they study beauty, symmetry is very important. Mm-hmm. So if your nose goes one way, your eye doesn't like it, I get that. I get that. All in nature, 2 strands of DNA, it's always symmetrical. But I can't tell you how many times I've been with like an orthodontist and I catch his wife's midline and get it down. And then I turn to the orthodontist and say, is your wife's midline right on, to the left or the right? And he's just like a deer in headlights. And then you'll be at a dental seminar and, a dentist sat next to his wife. Oh, that's my wife. And I'll say, yeah, okay, stop. Is her midline straight on, left, right? Nobody knows where the midline is.
It's tricky.
And then you have some orthodontists say, well, in order to get the midline right up, I got to pull 4 bicuspids or, all this stuff like that. And I'm like, is the midline even a for real thing?
I think it is sort of important. The best tip that I ever heard for determining the midline was from Dr. Steve Wagner. And he said, forget about nose and chin and, points and the floss. It's tricky. It's hard. What he encourages people to do is count the teeth on both sides of the smile. If you can, when they smile big, you can see all the way back to the first molar evenly on both sides, you're good. If you see the first molar on the left and you can't see it at all on the right, you might have a problem. And most people, what you want to see is a very beautiful symmetrical frame for the smile. And that approach has helped me with midline.
I've been to Avident. I think I went down there a couple of years ago. Is this mostly... I heard that at their symposium here in Phoenix that at least 40% of the dentists were prosthodontists.
I don't know.
Yeah, the numbers I got, it was like 690 dentists and 40% of those were prosthodontists. There's only 1,000 prosthodontists in the United States?
Not very many.
Yeah.
1,600, I think.
Is it 1,600? So if you had 690 and 40% prosthodontists, so the prosthodontists are, like, I'll back up where I'm going with this, like certain techniques that come out, say in perio or endo. And my first question to the rep would be, well, can you name an endodontist in town that uses this? Mm-hmm. And they'd say, oh yeah, Brad Gettleman. And then you'd think, well, he's like this patron saint of endodontist in Phoenix. So yeah, it's a buy. So are the prosthodontists buying into this? I mean, I think there'd be no greater thing you could tell the market than, those prosthodontists, they got a master's degree after their DDS. Yes. Yeah, they like it. Mm-hmm. Are the prosthodontists, were they all there in curiosity, or are they buying into this?
I think that a lot of them are starting to do it. So I think that prosthodontists are a weird group. So sometimes they're very old-fashioned. Sometimes they're very reluctant to change or accept new technology. But what has helped digital dentures is that there is a lot of actually good research and studies that support it. So I think that has helped prosthodontists get on board with it.
So when you send you're sending your digital via a DICOM file?
STL.
STL file to Avident here in Scottsdale. Mm-hmm. And it first goes to Phoenix, my house, and then we shift it up to Scottsdale. Do they CAD-CAM the teeth too, or are they using denture teeth from like Ivoclar or Dentsply or?
Either. So they offer like 3 different molds of conventional manufactured teeth that they will mill out the base and then put in the teeth.
Okay.
And that is the way that I think most people start out with digital dentures, because it's the conventional, the look of the denture is what they're used to. So you can have Ivoclar teeth or Dentsply teeth or whatever. But that's not what I do now. The first probably 100 or so cases I was using mostly bonded teeth. But after that, I switched to fully milled teeth, which is a technology that they have where they make a custom puck that has 3 different colors of resin in it, so 2 tooth shaded and 1 pink, into a custom puck. And then they mill the whole thing.
In one piece.
In one piece. So the teeth and the base are continuous. The whole thing is one piece. It's nothing that was ever luted together or bonded together. And that results in a denture that is one piece, which to me makes perfect sense that it would be stronger than a denture that has a denture tooth bonded in. So out of probably, I would say, 400 of those that I've placed in the mouth, I have had 4 fractures of the denture, and all of them, with the exception of one, were over implant bar structures where I really should have had a metal reinforcement. But for every single, with the exception of one, regular denture, 1 fracture out of probably 400. The teeth can't break out. The teeth, actually, you can throw it across the parking lot and it won't chip or break. I have a video on YouTube that shows me destroying a bunch of dentures. Actually, it's not on YouTube, it's on my Facebook. But I was.
Yeah, you're on Instagram and Facebook and YouTube.
Yes. So this, it's really exciting what the new products are for dentures. So just imagine your elderly patient who drops their dentures, and you can give them a product that's probably never going to break. Also, give somebody dentures maybe who has dementia, and know that if their family calls and says their denture is lost, you can just order another one without having to see them or nothing at all. You just type in your order.
Whenever you talk to an engineer, they don't think of right and wrong. They think of everything's a trade-off, redundancy, all that kind of stuff. And they, so obviously if a tooth is luted in, that's the weak spot. That's what's going to break.
Think about locator overdentures.
Yeah.
So that's right where they break.
Right. So you sit there, and if it's one piece, you just got rid of the weakest link.
Yep. So I've had 0 fractures over the locators.
Yeah. Now, so on your denture market, is it 50-50 boys, girls, or is one more likely to get dentures than the other?
I haven't looked at that, but it seems like I see more female patients.
Seems like more female?
Yeah.
And when you, what percent of your patients are the traditional nightmare that, they come in, 10 times and, you seem like you made them a denture and now they're your friend for life, versus you deliver and maybe no adjustments, 1 adjustment, 2 adjustments, they're off and running. How does that break down?
Well, I think it's tricky because I remember the ones who come in more, and I forget about the ones that get their dentures and then don't come back. So I feel like I have more of the difficult patients. I think that a lot of that is because the dentures that I offer are, in general, more expensive than most other options. So people who come to me are usually referred by general dentists in my community, which means there's usually a reason. But I don't back down from that, and I actually like it, so it's fine.
And is that because, where does that come from? Are you just a very competitive person? Are you just like challenge? Where does that come from?
I think it's just that I am very competitive. I will act like I'm not, but I kind of, I have that in me, and it's also just very rewarding when you can actually help someone who has a challenging case. And denture patients in general, I can't think of a dental patient that is more needing of extra help, better technology, innovations, things like that. Like our initial conversation, dentures are, it's a huge thing. They're hard to wear. It's very difficult to have them be a good prosthesis.
So when I got out of school in '87, the big trend was, the old-fashioned guys have all these rooms, and you want these open bays, and I think they just wanted to sell you cabinets. Back then it was Health Co. And I think they got bought up by
They needed something
Patterson.
new.
And so they were giving everybody all these cabinets. And I was hearing, again, I'm in Phoenix, so it's a little different demographics. Within a mile of my office, this is a retirement community. If you're retired east of the Mississippi, you go to Florida. If it's west of the Mississippi, you go to Phoenix. It just is what it is. So Phoenix, believe it or not, is 10% Canadian. And then it's, your North and South Dakota, Minnesota, all that stuff. And so many people would tell me, well, I can't go to that guy. I'm not, he wanted me to take my teeth out, and I can hear the lady in the next room, and I can hear a lady over there, and there's no privacy. And one lady said it to me and just punched me right between the eyes. She goes, do you think gynecologists would do that? And I realized, my God, of course they wouldn't do that. Right. And or proctologist or what have you. Do you see a lot of embarrassment about taking your teeth out? Do you recommend that there be a closed room with a closed door, or is that not? Or is that an overblown issue?
I haven't noticed that so much. I do have the typical, a female denture patients who's, I look in their mouth and I say, you have red, horribly swollen gums. Are you taking your dentures out at night? No. Can you? Never. I'll never do it. Because they're married, sleeping with a spouse. And they just won't do it. So there's that issue, but I've never really had them feel uncomfortable in the office. Although my office was built in the '80s, so
but is each very kind of closed. A closed?
Yes, very.
So it's all enclosed. It's not. You know what I'm talking about? The open cabinet deal.
Yeah, we don't have that.
Yeah, and so. I think that when all your bays are open, I don't think you're going to really have a denture practice.
Yeah, or a lot of denture offices, you don't need air water necessarily. You don't need your hookups, so you can have a chair in an op that's not even a fully functional op and still make dentures there.
So what do you recommend to a lady who's never taken out her teeth because of her spouse?
Well, I try not to make them feel bad and say, well, you'll just get yeast infections. You don't want to make them feel ashamed, but I do tell them if there's a time during the day that you could take them out, maybe for a few hours, that would be helpful. I also have them try to take them out for a little while and soak them in usually like a 10% bleach solution just to really kill everything in that denture before they put it back. And then gently massaging their gums. Sometimes you could also suggest like a power toothbrush if they want to just stimulate their gum tissues. That's also helpful. So it's not like you tell them, oh, well, it's too bad for you. You just try to figure something out.
What's that grip called, the denture grip?
Polygrip.
Polygrip. It's kind of weird because when some of my friends think that if someone comes in and gives you money, and at the end of the day they need polygrip, you failed as a clinician.
No.
Other people sit there and think, no, it made it better. Is polygrip a sign that you didn't do your job?
Absolutely not, because a lot of times even the best of dentures can fall out, especially with dry mouth. People with flabby ridges or just poor ridges in general. Also, people who have a lot of times neuromuscular problems and they just aren't very coordinated have a lot of trouble. So I don't think it's necessarily a sign of failure. I will tell people that my goal is to absolutely not have you wear any adhesive, but that it may not be reasonable depending on the case. So some cases, you should be able to get good fit, but there are a few cases where you can't.
So is the company Avident in Scottsdale, are they agnostic to the scanner, or are they partnered with BioLace and married there?
They are agnostic to the scanners. So you can send them any scan file as long as it outputs an STL.
I always notice my homies are You're more interested in a decision that affects a $30,000 scanner or a $100,000 laser than you are a $50 bottle of bonding agent. So that just is what it is. Well, as the dollars go up, their ears go up. It's more important.
Yeah.
So walk through your oral scanner decision. Why 3-shape?
This is a funny story. So, about 2 years ago, I was going along using impression materials, had no intraoral scanner, had no desire for one. People had asked me, oh, why don't you get an intraoral scanner? And I said, well, because I'm doing just fine. I don't need one. Impressions work great for me. And I work in the same office with 3 periodontists. And they came to me and said, hey, we're getting an intraoral scanner. We're getting a Trios. They already decided. Do you want to use it? And I said, okay, I'll give it a try, see how it goes, see if I like it. And I tried it, and probably within a week, I had to have it for I use it probably 10 times a day. And I could not imagine practicing without it at this point. And that is from a person who said, I really don't need it, to suddenly I love it. Now, I didn't actually buy it. I was just fortunate enough that the periodontists I work with are like, yeah, go ahead, use it 10 times a day. We use it once a day. So I am lucky. I would definitely buy it myself if I had to. At this point, like if they took it away from me, I would buy my own. But that's how it went.
So, I think the lowest hanging quality is always magnification. I mean, obviously, you wouldn't go to Stevie Wonder if he was your dentist. Then you have a man with vision, and then you have loops makes everyone better. And I think everybody knows that, but then when you go in their office, the wet hands don't have loops. The assistants don't have them. The hygienists don't have them. Anybody sticking their hand in their mouth, the quality, raises the whole boat. The endodontists use microscopes,
yeah.
And not a lot, maybe only 6 to 8 magnification.
Mm-hmm.
But is a lot of the thing that you love about the scanning the fact of seeing everything on a screen 25 to 40 times larger?
Yes.
Is that a big part of it?
Part of it. Also, you can virtually eliminate getting undercuts because you can spin your prep around, see it. You can eliminate not reducing enough because you can check your clearance. When you see your margins blown up, you're definitely going to do a better job. But the real benefit, I think, is that all of the benefits of just digital dentistry in general. So the fact that when you do your scan, if there's a margin that's not captured well, you don't have to redo the whole scan like you would an impression. You just rescan that area. Let's say you've finished your prep, and your assistant makes a temporary and part of the prep is sticking through the occlusal. Instead of having to re-prep the tooth, remake the provisional, redo the impression, you just delete the area, rescan it, you're good. So, and there's all of the archiving. Being able to capture the incisal edges of teeth before you prep them. Do your prep, then scan your preps, allows your lab to know where to put the incisal edge. There's just so many intangible benefits that help you with.
Now, do you have your own CBCT also?
Yes.
And what did you go with on that?
Again, my periodontist bought it, so they got an iCat, and I'm just lucky that I get to use it all the time. So I didn't make those decisions, but I think it's great.
It is very obvious to me, iCat. I mean, when somebody has a CBCT, if they're a specialist, if they're an oral surgeon or a periodontist, that's the number one brand.
Yeah, they got rid of they had a Serona, and they got rid of it because of I guess there were fees that were out of control. I don't know.
Well, it's amazing because, I mean, some of these scanners, and you'll buy a scanner and they have the first thing they're telling you is how much you'll save on impression material, and the next thing you know, the service agreement, it's $200 a month. Yeah. For your, and it's like, okay, well, that's $2,400 a year. Right. And then some of these other machines, it's even crazier. So it's like you got a great machine, but and I get it because it's the reoccurring revenue model. I mean, why is Netflix have the same value as Disney? Because Disney has to put $100 million into a movie. They hope it's a $300 million blockbuster. It's feast or famine, and sometimes they release movies that flop or whatever. Whereas Netflix, just every dang first of the month, you ding a gazillion credit cards for $10. So everybody wants that reoccurring revenue model, and if you that's why laser companies in the 30 years I've been on, I mean, I cannot tell you how many people came out with a laser, sold it for 50,000, sold 1,000 of them. So you're thinking 50,000 times 1,000. These are big numbers. And the next thing you hear, they're bankrupt. Well, they had big numbers, but if they had a summer dry spell and they didn't have enough savings to go through cash flows, I mean, if you need $1 a month for overhead and you don't have $3 in the bank, and after summer they're gone. So I get it. They all want the reoccurring revenue model.
And that's happening in printing companies now. I think it's fascinating. So 3D printers, it's a piece of technology that's easily could become obsolete. You could buy one and the next year could be obsolete. So there's a printing company that has moved towards a subscription model, which I think is really interesting, and you might be seeing more of that in just the general dental equipment market.
The reoccurring revenue model is getting bigger and bigger. Wall Street loves anything on a reoccurring revenue model, and then that's where you really got to do your homework. It's kind of like the price of a house. You know, you spend so much time looking at the price tag. You're like, well, this is $240, and I'd really like to do $220, and you're saying all these numbers that don't even mean anything because it's the interest rate. What are you putting down? What are you financing on? Is this a 15-year loan, a 30-year loan? So I mean, even Albert Einstein said that compounding interest was the most powerful force in the universe. So when you're looking at all these scanners and CBCTs, what are the financial terms? What are the software support deals? Can you get out of these? What is the cancellation fee? Because that's where everybody's focused. You know, there's a reason why you can go fill your house up with furniture and have no payment for the rest of the year. That should be your first red flag. Really? I can get all the furniture and no payment until next year? Yeah, because the financing, the non-cancellation, the interest charge. GMAC usually netted $3 of net income profit for every dollar GM did for the entire lengths of these companies. So, you know, everybody talks about the factories, the unions, the auto workers. That was $1 a profit. But the guys over here financing the car were making $3 a profit. So financing a car is a much better business to be into than actually making the damn car.
Interesting.
Very, very interesting. So I mean, your name is Denture Queen, but I didn't want to make this whole podcast about dentures.
Sure.
What you said, it's a traditional prosthodontic practice. So after, you know, other than dentures, what is a traditional prosthodontic? I mean, I doubt it's a single crown on a 6-year molar.
Correct. But, you know, I see a lot of patients referred for more complicated issues, people who've bruxed severely and need rehabs. So that happens sometimes that people can afford it. And then I do a lot of single anterior crowns where they want it to match really nicely. But one of the other areas that I'm kind of passionate about is what I would consider geriatric dentistry. And that kind of falls into what I do very often. So I sometimes see patients who are 90 and their dentist is just like, whoa, I just don't even know what to do here. And you know, they've got an old partial, it's barely hanging on and caries everywhere. And so I like to take cases like that, even though it's not fancy, all on fours. It's hold on, let's just take care of this person so they can chew for a few more years, and that's it. So
some of my regrets, 30 years, I mean, I got my fellowship in the mission suit probably before you were born. I'm not even going to ask. And but you would put 2 implants in and do a 3-unit bridge on both sides.
I've heard of that.
And then 20 years later, she's in a nursing home and her sister family's calling you in there and you're thinking, dang it, this 1 implant's lost. If I'd have done 3 implants, I could have just removed the 1. She wouldn't have known. Why did I save money by not just having 3 implants for 3 teeth. Why did I do 2 implants and a 3-year bridge? What do you think? Do you think treatment plan an implant per tooth, or almost like a spare tire?
Oh, I think an implant per tooth is kind of excessive. But I like to help people make decisions when they're younger about letting them think, how are we going to take care of your teeth so that when you are elderly and you are unable to go to the dentist, are you still going to have teeth to chew with? And are you still, going to be pain-free and doing well? So, because I see many people in their 60s and 70s who are, when they're presented with treatment, they're like, well, but, I'm 65.
Oh, I know.
I'm like, okay, well, people say that to me all day, just so that, and you have to try to get them to understand that I know you're looking at the next 10, 20 years of your life, but the last pleasures you have in life is eating food, I think. One of the last things that you can do and still enjoy when you're, a couple weeks from death possibly. So why not make it the best?
But at a couple weeks from death, when you gone to drinking at that point?
Probably.
But yeah, I'm so glad you brought that up, because looking back at the biggest mistakes I made in diagnosing and treatment planning, I was 25. I was in a retirement community, Phoenix, Arizona, all these retired people. And all these men, I tell them what they need, and they go, I'll be dead in a year, I'll be dead in 2 years. They were still alive 30 years later.
Yeah.
I had that, I definitely had that a heck of a lot more with men than women. But I'm telling you, when you're a young kid and some old man's telling you he's going to die, you have to do everything. At the minimum, he's going to live 5 more years. I mean, he just will. I mean, even when they tell you, look, I'm on cancer, I know, I've heard it all for 31 years. But you know what? You're going to be back here on my doorstep next year, the year after, the year after. You really, I think, in my practice, if this has to last at least 5 years. If I'm doing something and it can't last 5 years, then it's not even an option.
True. I would say that my focus on that is more for the patient where doing dentistry would possibly put them in a worse place. So if you have an elderly person with a partial that's barely hanging in, caries on all the teeth, 22 through 27, if you make them a lower denture, they're in a worse place than just keeping them with those carious teeth with the partial, maybe put silver fluoride on it, maybe just do some very conservative treatment just to keep them eating and out of pain for a few more years. The other factor is that I deal with a lot of people who have dementia, and I've become, really observant and trying to see dementia as it develops in people, and it can be a killer for your treatment. I'm sure you know this from just treating people for years and years, but once you get to that point where dementia happens, everything you do is more difficult and won't work as well. So if they have dementia and have the signs, then I feel like it's often better to step back and not do as much dentistry because it just won't go as well.
Are you using a lot more silver diamine fluoride for root surface decay than 10 years ago?
I don't think it was allowed 10 years ago, but yes. From what I know, it was approved in 2016, which is when I started using it about then. In
2016?
But I know that there are some promising research studies from Japan and Europe that they've been using it for a lot longer. I don't know for sure if it stops caries. I think we're still out on that. But I have been having people do it as an alternative to doing nothing. And I think it's a really good alternative than doing nothing. So if someone has, like I talked to you about caries, root caries, 22 through 27, their partial still works. I don't want to put them in a denture. We can't restore the teeth because if you tried to prep it, it's an apple core, for example. So in that case, I will do silver diamine, and I think we counted the other day, I've treated like 300 teeth or something with it. And so far, I really want to get more data so that I can see teeth that I've treated. Have they required extraction? And if so, how many? And I don't think the number is very high.
And what are you tracking this epidemiological data on?
I do all of my tracking with Open Dental.
You use Open Dental?
So I love it.
I know.
I just love it. But that's how I originally got involved with presenting about digital dentures, because I went through my Open Dental and I tracked before I went digital, how many dentures did I do, how many denture adjustment appointments were there, how many try-in appointments were there. And so I can't remember my exact numbers, but before I switched to digital dentures, I was doing on average 5 adjustments per denture, and that includes soft relines for immediates. And then that number went down to 3 adjustments per denture after I switched. But the try-ins were more, I went from doing like 3 try-ins per denture, 2.9, to about 0.5 try-ins per denture after I did digital. So then if you get out all your fancy math and you say that's 40-minute try-in appointments times however many try-ins, because if you do, 150 dentures a year, that's kind of a lot of time. So I was able to graph the change in clinical chair time as a result of doing digital dentures rather than conventional. The only catch is that I wasn't doing these comparisons side by side. I wasn't making conventional dentures and digital at the same time, which would be a scientifically valid way to examine it. I was looking at 2 different time periods, which means that part of the improvement I had was probably just that I'd been making dentures for longer and had gotten better. But I still think that some of that change was the result of making them digitally. And that was all Open Dental. And I
you
love...
have an amazing mind.
I really love to pour into these
So walk through, because they don't know about Open Dental, because Open Dental is the only one that doesn't advertise.
Yeah.
And Dentrix is the big boy. Eagle Soft would be number 2. Why did you not like those 2, and why did you like Open Dental?
My accountant recommended Open Dental when I started my practices, so that's kind of why I did it. But I do like the idea of it, and I think it's excellent software. It's very you can do a lot with it, and the bigger software companies, I just don't like their product as much.
I was lecturing in Toronto and Paris, and in both of those cities, some dentist said, "Oh yeah, I went with Open Dental because it's the only one where I could go in there and change the words to French or anything like this." Australia. Why do I like Open Dental? Because I could buy Open Dental and then go in there and change it to all the Australian coding.
I also get really crazy with customizing Open Dental. You can probably expect. So, as an example, all of my lab slips are custom lab slips in Open Dental, and then they print just like the lab slip that the lab wants you to use. But that way, when your assistant isn't writing the patient's name on the lab slip and misspelling it, it's Open Dental inserting that patient's name right where it ought to go. I also do extensive auto notes that are my own note and have prompts for each step in my checklist that I do. So I have loved customizing it, and so I really, really love it.
Have you gone to the point where you got a programmer to go in and add something to it? No,
but I have called them and had them figure out a couple of custom queries for me, which they will do.
Have you? Did you ever meet the founder,
Jordan Sparks? Jordan Sparks, no.
Is a dentist, and now his brother Nathan runs the whole show. The reason I switched from soft dent to Open Dental is because I got this accounting team, and the fact that their Dentrix and Eagle Soft doesn't talk to their Quicken or Peachtree or Microsoft GP. Microsoft bought Great Plains Accounting, so the Microsoft GP, the GP is for Great Plains. And you go into these dentists, and you ask them any of their numbers, they know none of the numbers. And then you see a big surge of these dashboard companies that are going in there and taking out data from Dentrix and trying to make them dashboard. Well, it's a lot better than nothing. But I I just love the dream that you can go in there and say, this is what we need. I'm going to get a programmer. I'm going to hook these two up myself. I'm going to customize this myself.
Yeah.
When, probably 25% to a third of everybody on this podcast is in dental school. I mean, old people, like all my drinking buddies couldn't find a podcast. If I handed them their iPhone and put a gun to their head and say, pull up any podcast or I'm going to shoot you, I'd have to shoot all my alcoholic dentist drinking buddies. So you're talking to a young crowd.
Okay.
And email me, howard@dentaltown.com, and tell me how young you are. And if you're younger than 12, just don't send me the email. When you look at the insurance graph of like, when I lecture at this insurance claims, there's like 300 people from the insurance company that show me all this data, but they won't publish it, they won't post it, it's all proprietary. But you look at the 32 teeth and dentistry, last year, 127 billion. It just looks like 4 spikes. It's like, boom, first molar. 3, 14, boom, 19, boom, 30, boom. What's the tooth most likely to be pulled? First molar, crown, first molar, root canal, first molar. It basically it's just 4 big spikes. I mean, when's the last time you did a root canal, bellum crown on an incisor? It's
no.
So they're in dental kindergarten and they're all wigged out of their mind to do a single crown. And then when you talk to the people at like big labs like Glidewell, they say like 96% of crowns come in 1 tooth at a time. The majority is just the first molar. Mm-hmm. What could a fancy dancy prosthodontist like you, what tips could you give to a person who's just trying to nail a single crown on a first molar?
Single crown. Well, I think that having the intraoral scanner would be my top choice because you can, like we mentioned earlier, you can see reduction, you can check all of the things that are important. You can check for undercuts and so on, but that is
so you'd still recommend
doing it digitally.
And you know what, I look at the 3Shape. By the way, I have my own theory. When you go to Denmark and you go to 3Shape in Copenhagen, or you go to Helsinki, Finland, and you go to Plan Mecca, I think the reason their companies are so amazing is because the country is frozen for all but like 4 months of the year. And when you go there during the winters, they just work 10-hour days. And they do. I mean, that's what they tell you. And they tell you that they say, in the Netherlands, during those long, cold, frozen winters, you're either going to drink 1,000 gallons of vodka, or you're just going to become a workaholic. And they just pour themselves into their work. And it's just, those are 2 of the most passionate countries I've ever seen. 3Shape and Plan Mecca. You just really, but again, the thing that I'm liking the most about it is simply the magnification deal. I remember the first time I scanned a tooth and I looked at the scan, I mean, I thought like my 5-year-old granddaughter prepped the tooth. I was like, because you're looking at it because you're thinking, well, this looks really, really good. Then you see it this big and you're like, is something wrong with me?
Yeah. The other thing that I would suggest is right now I have all of my scans going to a design service where I get to then view the designs and approve them before any crowns are manufactured.
And what design service is this?
Well, I use one called Full Contour, but what I love about it is it really helps you to see things about your prep that maybe weren't perfect.
Where so www.
Full Contour.
Full. See, my sausage fingers type dull. Full. I need to have a surgery reduction on my thumbs. Fullcontour.com.
Yes.
Okay.
And again, this is one of the things that I do because I'm a crazy prosthodontist and I want to be like involved. I don't want to sit there and click around and design things myself because that takes a lot of valuable time. But I like being more involved with seeing the designs, asking for changes, making sure that things are exactly how I want, and then I can have the designs approved by me, which is nice if you're a doctor who really wants to be more involved with the lab side, but you don't necessarily want to do the designing yourself. Like, I see a lot of doctors, playing around with Mesh Mixer, which I love doing that too. and designing things themselves. But the problem is that your best time is probably spent at the chair side or a couple minutes per patient doing additional steps. So I've found that having the ability to look at designs and make sure that they're good has helped me a lot.
So this is Rob Lazare.
Yes.
Oh, I know Rob and his son, Rob Lazare Jr. Nice. Jeremy Hischler. So where are they? Are they in Vegas?
No, they live in Phoenix.
Glendale, Arizona.
Yeah.
That's not Phoenix. They wish they were. Phoenix wannabes.
Okay, I don't know.
That is amazing. So they're also going to be asking questions on first molars. Just first molar. Does it need to be zirconium? Can it still be Ivoclar, Emax? Does old guys are doing PFMs? Mine are all full gold crowns.
I still do a lot of gold. Not a lot, but if a patient requests it, I think it's an excellent material. But
And who's the only one requesting it?
old guys. So
Did she just call me old? Oh my god! So if they have a liver spot, you go full gold.
yeah.
What if it's a grandpa and he says, "I want what's best"? Is that a default to full gold?
No, I actually think that zirconia is best. Although people can argue all around that issue. It's kind of a personal choice. I think that gold is wonderful, but if you can see it when they smile, I think that's not what I would want. That's not the best according to me. So I would want tooth color. But the reason I don't hardly ever use Emax or lithium disilicate anymore because they're a lot better, more translucent zirconias now. So like one of my favorite new zirconias is the Katana multi-layer, and you can tell it's not a lithium disilicate, but it looks pretty good. It's a little better, I think, in its qualities.
Spell the Katana multi-layer.
Katana. It's a Noritake brand, I think. And they make it from a multi-layered zirconia disc. So you have some translucencies that work into that disc, but the strength properties are still pretty good. That is my go-to for most first molars. I think that the problem with Emax or lithium disilicate is that you have to reduce a lot more. And I see, especially if you're putting lithium disilicate on a second molar and you've reduced it, you need like 2 millimeters in that case. So I think that's kind of aggressive for a second molar.
I'm trying to think. Could I know anything that a prosthodontist doesn't know? I might know.
Yes, plenty.
I might know just one thing. The ferrule.
Mm-hmm.
Do you know where that word actually comes from?
I might have heard it, but I forgot.
So the ferrule, because what's important is they have 2 millimeter structure all the way around.
For post and core.
Yeah, and you need that 2 millimeter. And if it's shaved off at the top and you're just going to have a post sticking out of there and a crown sticking on there, you don't have it. You have to have a ferrule.
Right.
And even though it's only 2 millimeters all the way around, it doesn't seem like, you know where that came from? Barrel making. Their barrels kept exploding. So what they did is they found out you just need one little wrap around the barrel. And then if it was really rich stuff that you couldn't lose, it wasn't water, but it was like wine, then they put a smaller ferrule underneath and a smaller one on top. But that's a ferrule, and they learned that from losing hundreds of barrels of good wine and liquor and whiskey. But that might be the only thing my walnut brain knows that a prosthodontist doesn't know. And then what would you cement them with?
I am really agnostic about cements. The one I use, I don't have a reason for. I use Reliex.
So, but you're a cementer, not a bonder. Doesn't have to be bonded.
You can bond if you're lacking mechanical retention. I like to just always have mechanical retention, but in a situation where you don't, then you would use a bonding agent. And then in that case, I use a Nexus resin cement.
And then I'll give you a time-saving tip.
Yeah.
When you go to take a shade, if he has a liver spot, don't. It's just an A35. And seriously, it's an A35. You see the liver spot, just put the shade guide away. Was there anything else that I wasn't smart enough to ask you?
No.
Really?
That's good, yeah.
Like, again, I love you. I love your mission. I love everything about you because I don't like to talk about religion, sex, politics, or violence. But like this last election that confused so many people, it was all the flyover states. Mm-hmm. And in dentistry, those were all on none states.
Right.
And they got tired of the all on 4 states, or communities. And again, I know it's the hottest thing in every convention, but if I see one more all-on-4 lecture, I'm going to puke, because take the 400-pound gorilla in that space, clear choice, right? And they charge 25,000 arch, and last year they did about 18,000 arches. Well, you look at a country with 324 million people. And in fact, I'm just gonna do the math right here once and for all. So you take 18,000 arches divided by 324,000,000. I mean, you're talking about 0.00005. I mean, it's like, dude, America is not about making rich stuff for the wealthy. This wasn't a country about, like when Henry Ford started his car, a lot of Americans think that Henry Ford invented the car. Now that was Daimler Benz, and his daughter was named Mercedes. But when Henry started that car company, there were 86 car companies that would make just really expensive cars for rich kings and queens and noble landlords. And Henry said, you got to make this stuff for the masses. And that's what America was built on, the middle class. And I wish you had to see 100 all-on-none denture courses for every all-on-4 implant course. And I just think it's amazing. Congratulations on being the keynote speaker of two of the biggest meetings in town this year. And in between sandwiching in a short, fat, bald guy in Phoenix, it was an honor to podcast.
Thank you so much.